America is home to 33 million small businesses, the beating heart of communities across the country.
And proof that the American dream is still alive.
This is a show about those dreamers and doers and the communities they serve.
Their real life stories.
Their struggles and successes.
Their grit, determination, and passion.
And the people who fight
to keep their American dream alive.
I'm Alfredo Ortiz.
I'm Elaine Parker.
And it's time for another episode of Main Street Matters,
America's small business megaphone.
Hi, everybody, and welcome to Main Street Matters, America's small business megaphone. I'm Elaine Parker, the president of the Job Creators Network Foundation. And joining us today is Dr. Lee Gross, a board-certified family physician and national leader in healthcare reform, who has spent over 2 decades serving patients in Florida. He's the president of Docs for Patient Care Foundation and a leading voice on direct primary care, even testifying before the U.S. Senate and advising the White House on healthcare policy. Dr. Gross brings a frontline perspective on how we can expand access and lower costs through real market-driven solutions. Dr. Gross, welcome to Main Street Matters.
Thanks, Elaine. Great to join you.
Well, I don't think it gets any more Main Street than primary care and the importance that we place on our primary care doctors, because they are our frontline physicians. They're the people that we have the closest relationship with in managing our healthcare, and they're the people we call when we don't feel well or worried about our kids. So you're a very important figure in a lot of people's lives, and I just wonder if you can tell us about sort of your perspective on primary care, and then your practice of what direct primary care is.
Yeah, so primary care, of course, is where the rubber meets the road when it comes to healthcare delivery. And we say that 85% of what can be done in healthcare can really be accomplished at a primary care level. But the demands that are being placed on primary care, the way our current system is designed with intense regulations and constant reporting requirements and technology requirements, and gets to a point where it becomes overly distracting for primary care to be delivered efficiently, which is where you end up with your 5-minute primary care office visits and so forth. So, under our current system, the primary care is so overstressed and overburdened that it becomes very difficult to actually do his or her job effectively. So essentially, everything gets referred out. But what we did, in my practice, we have what's called direct primary care, and I think you've discussed this on other podcasts. But the name of my practice is Epiphany Health, and Epiphany is a pretty strange name for a healthcare company. But we were a traditionally insured primary care practice. We had taken care of all the patients under the standard fee-for-service medicine. But it got to the point where the insurance companies were driving so much of the decisions and creating such a distraction that we thought, that there must be a better way to do this. And the epiphany came when a small business owner approached us. So it was actually founded by small business that came to us and said, look, I can't afford health insurance for my employees. And I see what I pay for health insurance and I see what they pay you. And we're both getting taken advantage of. And you're already taking care of all of my employees. Why don't I just hire you directly to take care of my employees? And then you'll probably do better and we'll do better. And so our epiphany moment was, why are we insuring primary care? Why are we inserting so many obstacles and barriers between a doctor and patient, filing an insurance claim for every single interaction, and creating something that should be relational care and making it transactional care? And so then we're upset and disappointed that it's inefficient, it's impersonal, it's cumbersome, it's expensive. And so we pulled the trigger about 16 years ago now, where we fired all the insurance companies and we started a subscription-based primary care program where we charge a flat monthly fee for all the services that we provide in our office. And then we don't bill any insurance company for any services. We don't charge anything on a fee-for-service basis. And everything that can be done in our office is included in our membership fee. So unlimited office visits, unlimited technology visits, unlimited telemedicine visits, email visits, in-office testing and procedures, strep tests, urinalysis, biopsies, joint injections, EKGs, Holter monitors, all that is included in our subscription price. And at the moment, we're charged $93 a month for adults $30 a month for the first child and $15 a month for each additional child. Um, and that price is largely unchanged now in about 16 years. It's about the same price we charged 16 years ago. The interesting thing happened when we flipped the switch on that practice model is that uninsured patients came to our practice in Southwest Florida from all over the state of Florida. So I, a little unknown primary care doc in Northport, Florida, see patients from Miami, see patients from Orlando, see patients from Tampa. They're driving hours away past hundreds of doctors to get their primary care because they can afford what it is that we do. So it created an interesting challenge for us because we now had a lot of cash paying consumers, and we could provide the care in our office. But what happens if they need stuff outside of our office? What happens if they need labs? What happens if they need x-rays? And so we reached out to our partners that we were already working with in the community and said, if I sent you a cash paying patient that agreed to pay you at the time of service and you didn't have to deal with the insurance company, what could you sell your services for? And the fascinating thing is that the prices that we were getting were astronomically affordable. So a CT scan or a CAT scan that you would think would be thousands of dollars is $175. Why are we insuring a $175 CAT scan? An MRI that you would think would be anywhere from $4,000 to $10,000 because you've seen the crazy hospital bills. It's $275 and it hasn't changed in 15 years. The blood work that we get, same thing. If you ask the lab, what is the most expensive thing that you do? They will tell you it's not a lab. The most expensive thing they do is interact with an insurance company. And so if you eliminate the need for them to create codes and collections and track down um, fees and deductibles and chase people down for payments, then it takes out 80 to 90% of the cost of the labs. So our patients can buy $2,000 worth of blood work for about $80. Um, so we've now created an entire cash-based economy in routine healthcare delivery services, and we've been doing it now on a cash basis for 15 years. So I live in a different world than everybody else, and I'm sorry to just kind of ramble on you here, but I'm at a point right now in my world where most of my patients now do have insurance. They just don't use it in my office. They use it for big things like hospitalizations or major surgeries. But it's at a point right now where when they pull out their insurance card, things don't get cheaper, then they don't get faster, they get more expensive, and they get further delayed. So, for example, if you have a commercial insurance plan and you want to get an MRI, we've got to fight for approval. It can take 3 days to get the approval. Oftentimes they're denied or delayed 2 or 3 months for various obstacles they may put in the way. And then your copay may be $500, $600 for a CAT scan or for an MRI that I could get tomorrow for $275 if we paid cash for it. So what are we insuring if the use of the insurance slows down the cost of care, makes it harder to attain?
Just for instance, $2,000 worth of blood work you can do for $80 through
Yeah.
your partners, your cash pay partners, like a lab somewhere, a local lab. Are you literally telling me that the $1,920 is all the middlemen? I mean, that's insane to me. That's highway robbery to
Yeah.
me.
Yeah, it's absolute bloat in the system. It's third parties. It's the cost of complexity. So I've testified before the Senate a couple times. The first time I testified before the Senate, Senator Lamar Alexander from Tennessee, asked me a question. He said, "If I do the math," he said, "you're charging about $1,000 a year for unlimited healthcare services." And he said, when we send somebody to get healthcare delivered through the federally qualified health centers, we pay $5,000 per year. So why is it 5 times more expensive through an FQHC? And my answer was, you're paying $1,000 for the primary care and $4,000 for a federal bureaucracy to implement it. That is the cost of middlemen. That's the cost of immense amounts of human labor that are solely designed to handle the complexities of this mousetrap that we've built. And when you bypass all of that, you can focus all of your human labor and efforts on patient care. You're no longer distracted. I kind of, you know, compare it to texting and driving. That distraction. If you're not focused on the road, with all these distractions of the third party payers in the exam room, you're losing focus on the patient. I sort of joked when I met with members of Congress. I said, every time you folks pass reforms, you forget two people, and that's the doctor and the patient.
You've had a bird's eye view of the healthcare system for a very long time as a practice that took insurance and went through that system, and now a practice that is cash pay and does not deal with insurance companies. In that time period, the Affordable Care Act, or Obamacare, as we all know it, passed in 2010. It was probably fully implemented by 2012, 2013. What has been I'm not saying the system wasn't broken pre-Obamacare, because I believe it was. But what has been your sort of view on what Obamacare has done to the system that we all agree was already not perfect?
Yeah, I mean, I think the car was already heading towards the cliff. That's just the Affordable Care Act just, pushed the foot down on the accelerator a little faster. Um, I think in hindsight, it absolutely has driven much of the consolidation that you're seeing in healthcare, essentially driving private doctors out of independent practice and under corporate control, hospital ownership, decreasing choices and increasing cost. So that is an absolute outcome and a predictable one of the Affordable Care Act. Uh, One of the other things I think that the ACA has shown us is that coverage is not healthcare. Merely giving somebody an insurance card does not guarantee them access to care. And in fact, what I've just explained in the opening here is that oftentimes the coverage is a barrier to care. Um, the One of the complexities that's, and I don't want to go down a rabbit hole too far, but one of the little known rules in the Affordable Care Act is something called a medical loss ratio, which says that when an insurance company collects $1 in premiums, they have to spend 80 cents of that dollar on healthcare services, and the 20 cents that are left over, they have to spend that on operational costs and profit. So if I come to them and I say, I have a great primary care delivery system that's going to save you 30%. That 30% shrinks the entire pie. And so it's going to shrink their 20%. It's going to shrink their profits. So you would think that the incentive would be in the system for an insurance company to go out and find the best care at the most affordable price. But in fact, they're incentivized actually to grow their spend, because the only way to grow their 20% is to grow the entire pie. And that's to grow how much money they're spending on healthcare, to increase costs. So it actually has perverse incentives built within the Affordable Care Act to intentionally drive up costs. That's what it does.
So, do you think that the direct primary care system is a way to incentivize patients to make the demand for less expensive healthcare? Hopefully, I'm asking this correctly.
Yeah, I think that direct primary care is a tool, not the tool. I think it's part of the answer. It is not the answer. It is not a silver bullet. I would never portray it to be the sole solution. I think one of the important things is that the federal government takes a one size fits all approach to healthcare. And when you paint a country as diverse as the United States and as large as the United States with such a broad brush that all patients need to be treated the same, that's just not feasible. I mean, so what works in Southwest Florida is not going to work in Manhattan, is not going to work in rural Alaska. But yet, when you're saying everybody has to be handled through the same programs, then you are saying it has to be mass production medicine. We're at a point in healthcare delivery right now in our country where we can personalize somebody's care down to their own individual DNA. And so what we need in medicine is mass personalization, not mass production. And so the direct primary care movement allows that one-on-one individual care, allows patients and doctors to make decisions based upon the individual sitting in front of them, and not an arbitrary third party making rules on payments and what you can bill for and what services you can have and when you can have them.
And you also are the president of Doctors for Patient Care Foundation. Tell me about that organization, and is there a role for you helping to scale up what you're doing for the foundation to scale it up in terms of helping other, 'cause this is like helping small business owners start their business, right?
Right.
Because these are doctors who are going to leave a profession that, regardless of how broken it is, that's where their income is coming from. And you have to start with patient one, right?
Right.
You have to start with patient one, that first membership. And it's hard to kind of look forward and say, okay, so is there eh, I'm curious on the business side of it. Like, is there a business model that you help other doctors do this?
Sure. So Docs for Patient Care Foundation is a nonprofit educational foundation where it's also a physician-run health policy think tank, where we put out policies and recommendations for state and federal health reforms. But part of that is education. So we took a multi-pronged approach to specifically the direct primary care issue and said that this is a three-legged stool. We need to focus on the supply side, which is the physicians able to provide these direct primary care services. We need to focus on the demand side, which is educating patients that these services are available and what they are and how they should look for them, through op-eds and formats like this. And then the regulatory model where you're working on with policymakers to help promote a federal and state environment that is friendly to the practice model and the continued growth, and to get rid of the headwinds for that. And so we've been doing that now for many, many years. And on the supply side, we have put together a series of conferences and programs where we teach physicians how to start up and run these practices. I'm an old guy, so when I was in training, they actually taught the practice of medicine. They actually taught the business of medicine in your training. So when I left, I understood how to run a business. I understood the finances. I understood the complexities of hiring and firing and OSHA compliance and how to pay your staff and how to to not run afoul of labor laws. That was all trained to me. None of that is trained. Um, the next generation of physicians is all trained specifically to be employees. So when they come out, even if they wanted to go to a rural setting and hang up a shingle and practice, they don't know how to run a business. They've never run a business. So that's what we do is we focus on just the nuts and bolts, and our conferences are called nuts and bolts conferences. The nuts and bolts of starting up a practice, the nuts and bolts of running a business, and we provide them all the tools and resources that they need in order to start this up. How do you market? How do you find it? How do you fund it? And so we've been doing that now for I think our first conference was in 2016. We've had almost 2,000 physicians come through our training program, and we've had doctors come to our training program from all 50 states.
That's what I was going to ask you. How are the state um, regulations in terms of barriers in certain states? Is it harder to do this in some states, easier in others?
It is definitely harder in some and easier than others. It's definitely easier today than it was for me in 2010. So the legal question at the state level is if a doctor and patient contract directly with each other for healthcare services, and the doctor charges a flat fee for unlimited services, doesn't the doctor become an insurance company? Should the doctor be regulated as an insurance company? And that was our very first question that we asked: Are you a health plan? And so I reached out to my state lawmaker, who was a ER physician, and said, "Hey, I just need one line of legislation in the Florida legislature that says uh, if a doctor and patient contract together, the doctor's not an insurance company." And he said, "Well, who do you think might be opposed to something like that?" I said, "Well, maybe the insurance companies and maybe some hospital systems." He said, "Oh, besides Godzilla and King Kong, anybody else you think might be opposed to this?" It took me 7 years to pass that legislation in the state of Florida. Um, Fortunately, we've been able to pass that now, and I think 37 states, similar legislation protecting the practice model. I just provided testimony just this last week in Minnesota. We're working on some other reforms in Massachusetts now as well. So there are other regulatory barriers that we're knocking down now that the practice model is becoming a lot more popular. Of course, there are also some federal changes that have happened. Most recently, the health savings account provisions in the One Big Beautiful Bill, the HR1 that recently passed. That was the health savings account expansions that we've been now fighting for 15 years, finally passed.
Tell us about that, because that was a huge Well, other people outside of this fight may not understand the significance of this. I do, and I know you do, but helping people understand this has been a project of mine recently.
Yeah, so health savings account has very specific rules on what complies with that. You have to own a qualified health plan, which is very clearly defined in the statute. You can only have one health plan. You can't have a second health plan. And so the first question that we were dealing with the Treasury Department and the Internal Revenue Service is: does a subscription for the promise of healthcare services, is that a health service? So is the promise of unlimited care actually care? Um, and that was undecided. And the second one is that membership now a health plan that disqualifies having a health savings account? And so for all these years, the Treasury unofficially took a position that it is a disqualifying health plan, and that it's probably a qualified expense, but they never actually came out and said it. So it wasn't until HR 1, where that provision was put in, that clearly defines that a direct primary care subscription based model is not a health plan that disqualifies your HSA, and it is a qualified medical expense. So, again, 15 years worth of work and running back and forth to Washington, executive orders from the president in 2019, that still didn't get implemented until we finally got this into law. So this was a big win for us. It was a big win for the model. It's a big win for America, for small businesses.
Do you think that it will help you? Because one of the things you're basically describing is you have the unenviable challenge of growing demand and supply at the same time. Because if the demand grows and there's no supply, then the demand goes away. If there's
Right.
a ton of supply and no demand, your supply is going to go away because doctors have to make a living. I think some people think doctors are doctors to be nonprofit, that
Right.
they don't pay bills. But like every other person in this country, we all have bills to pay. So, do you think that that helps grow the demand and the supply at the same time now that there's legislation that says you can use these HSAs to pay this expense?
I most definitely think it does. I mean, it gives the model credibility. I mean, it is now formally recognized by the federal government as a legitimate care model. Uh, yeah, I always thought it was a legitimate care model, but now the government recognizes that crazy idea that we had, sitting in our office is now, informal federal policy. So that helps. I think it helps get awareness out in the community. It's going to be in IRS publications. Um, and it also opens it up to businesses that were interested in funding health savings account for their employees, that were afraid to do so in the past because their accountants were telling them they couldn't do it. Um, Now we've been accepting HSA payments from patients for, since 2010, because we always knew we weren't a health plan. We always knew we were a health expense, but now it's official, so it makes it easier. The barriers to adoption are, being kicked over. This was a big one.
You mentioned you recently testified. You testified before the U.S. Senate Special Committee on Aging, and I know you work closely with Senator Rick Scott. Tell us about your testimony, what prompted it, and what were some of your main points in your testimony.
I think the big focus that they're having is that they are seeing way too much consolidation in the healthcare space, as I had alluded to earlier. And the question is what role the federal policies have in driving that consolidation. And that's kind of what I laid out in my testimony, is that the immense regulation, creates so much drag and creates such an overhead expense that it's just, and also when you drive down the payments that insurers and the federal government pay to doctors for services, at the same time increasing their regulatory workload, the only way that they can comply is to spread that compliance over huge practices. And so that forces an independent small doctor practice to sell out to large corporation, large institution. And unfortunately, in those large corporations and large institutions, the primary care is no longer considered to be that sort of rubber meets the road healthcare delivery, they're now looked more at as a referral source that steers volume into their system. It's all about sort of controlling referrals, steering labs into the system, steering referrals into the system, and so that was kind of what we got at there. I did bring up the concept or the issue of the opting out of Medicare requirements of the federal government, which is the next regulatory focus that we're working on. And what I mean by that is the federal government, when it comes to Medicare, takes a one-size-fits-all approach to healthcare. And if you are a Medicare eligible patient and I contract directly with you for services, I must by law opt out of the Medicare system. Um, and you are not allowed to file for reimbursement from Medicare for services that you pay me for. That's federal law.
You as the doctor or me as the patient has to
I,
opt out of
I
Medicare?
as a doctor cannot bill Medicare. I as a doctor must opt out of the system across the board. And you as a patient are not allowed to seek reimbursement for my services from Medicare as well. So you can still use your Medicare anywhere else, any other doctor's office or facility, but you can't use it in my office.
Even though
Um,
it would cost Medicare $93 a month versus what is being paid out in Medicare?
it it would cost them immensely less than that because the amount of money we save the system by doing primary care better is enormous. I mean, absolutely astronomical. And I could certainly go into some of those numbers, but I'm going to say 50% is what our typical experience is. That when we implement a direct primary care model into a health plan, we typically save between 30 to 50%, and we sustain those savings over many, many years.
I mean, if
Um,
your model breaks into the Medicare system, it's like breaking into, like, organized crime. And I mean, don't you agree? I mean, you're basically breaking up a cabal that is, the financial benefit going, for those who are recipients and part of the whole Medicare food chain. I mean, you'd be breaking up a cabal that is tantamount to organized crime. Yeah.
there's a reason this is so complicated and why something so simple can take such an immense amount of effort and time and money to do these sorts of things. You're right. The system is broken on purpose. It is. There's a reason this is not getting fixed for the exact reasons that you just highlighted. Um, but the way that the system for as far as opting out is done is, if I'm opted out in one environment, I have to opt out in every environment. So I can't say I'm going to set up a corporation and do my direct primary care here, but then I'm going to have another business that I can work with Medicare. It is an all or nothing proposition, which means once I set up a direct primary care and enroll my first Medicare patient, I have to opt out in my urgent care moonlighting. I have to opt out in my telemedicine. I can't take ER shifts in the hospital, the rural hospital. I can't do hospitalist shifts and take care of patients in the hospital setting. So you lose all other sources of
But
revenue
that's the
while you're trying to build your
So
business.
that's the issue. I wasn't quite understanding the opt out, because if you don't take insurance, it wouldn't matter so much in your DPC practice. But other areas is where it impacts you in taking ER shifts, which, I mean,
Right.
that's huge.
So if I were a rural doctor, and I wanted to set up a new primary care practice, in order for a primary care practice to be financially viable, you need 3 to 5,000 patients. You need to be seeing 30, 40 people a day. You need to have huge staff. And you're not going to get that in a rural setting. It's going to take you forever to build up that practice. So you're going to need some state and federal subsidies to keep that practice afloat. You're going to need some financial assistance from local hospitals or charities to keep that going. A direct primary care practice, if run efficiently, can be financially viable between 300 and 600 patients. Um, and so that's ideal for a rural community where patients are very spread out. There's not a lot of population volume. May need an immense amount of telemedicine services because of the distance that has to be covered. So a direct primary care setting is phenomenal for those rural areas. However, in those rural areas, that doctor is also your ER doctor. That doctor is also the one that's taking care of all the patients that come to the hospital. So if you have to opt out in all situations, These doctors are going to do direct primary care anyways. They have to. It's the only way that a practice can be financially viable in the current world. Now you've lost your ER doctor, you've lost your hospital care, you've lost your urgent care center, you've lost doctors' abilities to moonlight in other various settings to generate revenue while they're building their practice. And so what we're proposing is a hybrid structure where you can have location-specific opt-outs, where you can opt out in your direct primary care clinic, but be opted in other practice settings. And so,
What's the appetite for that on the Hill?
we're just educating right now. I would say that my testimony in the Senate was very well received, and we're having follow-up dialogues about that. We're just gauging interest in the House, and our initial conversations is encouraging. Um, and of course, they got to run all the traps on that and see, okay, well, how is somebody going to game the system if we create this opt out? So we got to work through all those scenarios because it's never been done before. But we have some draft legislation that we're proposing, and I encourage that. Hopefully, it won't take 10 years to do that.
So does that mean so let's say that you could take a Medicare patient. Does that mean that they can get reimbursed from Medicare by becoming a member in your practice?
It would not. That's not what we're proposing.
Okay.
Now, I think Medicare Advantage can kind of do that now. So if you did a Medicare Advantage plan, they have a little more flexibility in how they do things. Um, and also within the Medicare Innovation Program, the CMMI, Center for Medicare and Medicaid Innovation, they have some wiggle room within the statute to be creative. So one of the things that we proposed was marrying direct primary care with a Medicare Advantage higher deductible plan. So, say for example, you had a Medicare Advantage plan that had a $5,000 deductible. The federal government could put $3,000 into a Medicare savings account that now the patient controls that would be eligible to sign up for direct primary care. The first $3,000 is sort of supported by taxpayer dollars, probably your money. Your premium is basically given back to you to get direct primary care, and then after $5,000, it would kick in, and you'd have full coverage for major medical. I know Dr. Savage has said, last time, 95% of patients never spend more than $5,000 in any given calendar year.
Right. Yeah, I mean that is very true. So what do you see as far as you're working on this reforms on the Medicare side, in the growth of DPC? Do you see a way to sort of create the tipping point? I guess is the best way to ask the tipping point on DPC care and practices where the supply is there, the demand is there, and we could actually start to move. I feel like if we could move, I'm such a proponent of this. It's hard for me to sit here and be calm when I'm talking about it
Right.
because I just think it is literally a life. It's like life saving. It's life changing. It changes my whole perspective on healthcare delivery. And I have traditional insurance, but I choose direct primary care for all my primary care needs. And that's primarily where I get my healthcare delivery from now. So for me, it's been life changing. Um, how do we get how do we get the word out? How do we overcome all of those barriers and get the word out to people that this exists, that it's affordable, that it's better, that you can get to your doctor when you need to talk to your doctor? I mean, I could do 6 commercials for you right now.
Yeah, once you see it, it's hard to unsee it. I mean, it does actually sell itself. I would certainly say that the rate limiting step right now is convincing doctors that there's a viable path forward. You can have a good career by stepping into this, and we will find ways to uh, mitigate your risk in starting these practices. But that's why we're trying to do all these things sort of simultaneously. Always say, rising tides raise all ships. So, if I go and convince a large company to sign up for direct primary care, but there's not enough doctors to take care of all those patients, then is that really a viable solution? So we need to again, I think fixing this HSA issue was a big stone to kick over at easing the headwinds of starting up these practices. Um, more people are interested in helping finance the startup of these practices. So that happens. One of the other projects that I'm working on is a company called Vine Health. Vine Health is effectively intended to be a marketplace that connects buyers and sellers, sort of like the Expedia of direct primary care, where employers or individuals or even governments can put money into an account that the patient controls, and allow the doctors to compete on price and quality based upon services. And they have to answer to the consumer. So just like you're looking for a hotel that's within 5 miles of the airport that has a restaurant that allows pets, um, you can look for a direct primary care doctor. I want that doctor to be female. I'd like her to see children. I'd like them to have evening or weekend hours. I'd like them to do texting. I'd like them to have a pharmacy. And you can search for those things, and you can look and see what services are available and what those prices are. But the Vine Health platform that we're putting together does not set the prices like third party payers do. They don't come in and say, we're going to sell this service and this is what you have to charge for it, and these are the services you need to provide. So we're trying to create that consumer facing marketplace because I believe that the only way you're truly going to bring down the cost of healthcare and improve the quality is through fair market and free market competition. You're not going to do it through federal mandates. You're not going to do it through setting quality metrics. You're going to do it through patient-controlled dollars and them using those dollars directly to purchase services. And as we fill in that platform, that will expand to imaging services and specialty services and laboratory services and so forth. So we're building that out right now. Unfortunately, we're running into exactly what you said, is that there is a limitation on direct primary care doctors, and so we're having to fill in a lot of that with telemedicine.
Well, I mean, think about it. It's also changing patients, also known as consumers,
Right?
mindset on healthcare. And so think about when your kids were younger or my kids were younger and I was looking for braces for them. Guess what I did? I shopped and compared prices and the services that I was going to get from those orthodontists. And you know why? Because it's expensive. And there's
Yeah.
not really orthodontia coverage. I mean, it's sort of a fallacy if you have a little bit of coverage in your, but it's kind of like beyond filling a cavity, you don't have dental coverage. There's just most of it's out of your pocket. And so what
Right.
do we do when it's out of our pocket? We shop. We shop for the best doctor, the best price, for the best quality, and the most services we can get, right? And
Yeah.
so we have to change that mindset of patients so that they view themselves as consumers of healthcare services. You can't shop for your next heart attack, but you can shop for a lot of things with regard to your health in terms of x-rays and scans and blood tests and all of those things you just talked about, but we have to change the mindset.
Yeah, you're absolutely right. So the pushback is, since you can't shop for your heart attack, then we shouldn't shop for anything. Um,
Right.
so if we can't fix 100% of the healthcare system, we shouldn't fix 85% of it. That's the preposterous argument, counter argument to what we're proposing. Is if you can't fix it all, then what's the point of even bothering? And so that's sort of my frustration point. But the more I do this, the more I'm shocked at what you can shop around. You can shop around childbirth. You can shop around hip replacements. And then when you're dealing with a self-insured employer, you can shop around building a network. You can incentivize employees and on creative plan design as to that we're gonna encourage you to go to the best doctor at the best price. And that's what we did when we built the health plan around DeSoto Memorial Hospital, which we've been servicing that hospital's employee health plan now for since probably going on to 7 years now.
Mhm.
And when we stepped in and built that plan, we took out their networks, we eliminated their networks, and said, "You go wherever you want, but we're going to go ahead and put tools in that allow you to see who provides the best care at the best price. And then we're going to say, if you go here, it's going to be free to you. You can go wherever you want. You can go to Mayo, you can go to Shands, or if you go here, it costs you nothing. We'll waive all copays and deductibles. Go wherever you want." And you know what? They went where they wanted to, and a lot of times they went where it was free, and that was good for the health plan. But it was never a no. And the other interesting thing we did is we eliminated copays and deductibles. So if they signed up for our plan, for our practice, the hospital paid for it for them. And so they had no copays for most of their care. Any of the work services that were done at the hospital were free to the employee. So free CAT scans, free MRI, free blood work, free surgeries. And they eliminated all the deductibles. And you would think that by eliminating all those cost barriers, that the price of the plan would go up, but we saved them 52% in the first year. And so we saved them, I think, $1.2 million in the very first year of that plan implementation. And we sustained that now for almost 7 years. Um, it's millions and millions of dollars saved
Yes.
by not putting up and raising deductibles, not by denying care, not by having restrictive networks, but by doing the exact opposite, by by increasing transparency, increasing accountability, sharing that accountability across the employees, and letting them know that, hey, when we spend a fortune, that fortune is going to come back to you in increased premiums next year. So we're kind of all in this together, and so it's been a phenomenal success.
I think it's fantastic. And when you have the opportunity to help people learn about this option, um, you can see light bulbs go off in their heads. And like I said, for me, it was life changing. It was life saving. And I never stopped talking about this type of plan. I know I've had your colleagues on, and you thought, well, aren't we just talking about the same thing that you just talked to my colleague, Dr. Savage, about? And I don't care. Like, I think this is so important that it's worth talking about on a regular basis, so that we can get the work out. So I thank you for what you're doing, and the work that you're putting into helping grow the model, not just your own practice, but the model. Because otherwise, we're going to end up in a single payer system. And I'm frightened of that for our future, and what it could mean. So, thank you so much, Dr. Gross, for joining our show, for doing what you're doing, and taking time out to educate people on a regular basis.
And thank you for allowing me to continue to spread the word and for continuing to share the stories.
Yes. So thank you all for taking the time to tune in to Main Street Matters, America's small business megaphone. Main Street Matters is part of the Salem Podcast Network. New episodes debut every Wednesday and Friday. You can subscribe to the show wherever you get your podcast from, and we will be back soon with another episode. Bye for now.